So continuing on with our series looking at anatomy and physiology, with motion being the central point of meaning, or the central point of our network of meaning, or the central point in the semantic network, we're looking at rib motion. Now you can also say respiratory motion, but most of this motion is going to be centered around the ribs themselves. And we talked very generally about the ribs within the first portion of the series on thoracic motion, so on thoracic flexion. So we will start this off by talking about the main objectives. And the main objectives, specific discussion of what rib motion is claimed to be with respect to planes and axes, as well as what the practitioner will experience, because there is a variation here. The general discussion of the muscles that generate rib motion, so quiet breathing as well as essentially forced breathing. General discussion of the nerves that supply the muscles of rib motion. General discussion of the vascular supply. So a lot of that has already been done in previous sections. So some of it with respect to what's going on in the neck and what's going on with thoracic motion generally. So some of that's already occurred. General discussion of lung function. All right, so there's going to be a decent amount on this, but it's going to be an overview. It's not going to be extremely detailed. Then a general discussion of the areas to assess and treat should rib motion issues be suspected or reported by the patient. Now that, again, is going to be extremely similar to everything that we've said with respect to thoracic flexion, thoracic extension, and thoracic side bending and rotation. However, we will still touch on it. Repetition has a large amount of value, especially when you're creating a network of meaning. So when you're creating a semantic network, when things are essentially different details but cross over with other things or with varying details, then they connect much better and you can understand how they play off of each other and work with one another. So as far as planes are concerned and as far as rib motion is concerned, so first we just do our general overview of planes. So the sagittal plane is a 50% cut of the body left to right. The horizontal or transverse plane is a 50% cut to the body top to bottom. The frontal or coronal plane is a 50% cut back to front. Axes being perpendicular. So the sagittal plane, it is going to have a horizontal or transverse axis. The horizontal plane or the transverse plane is going to have a vertical axis, and the frontal plane is, or the coronal plane, is going to have an AP or PA axis. Now, with respect to rib motion, what you're going to hear is the upper ribs, and you will hear varying numbers for the ribs with respect to the upper. You'll hear 1 to 3, 1 to 4. It will be, that's up for discussion, or at least reported in a variable way depending on the resource. They are called pump handle, so like this. So essentially what the claim is that it is more or less forwards and backwards bending. So it's almost like extension and flexion. So bending towards the back of the body and bending towards the front of the body. So that, if you're going to agree with that, then that is essentially flexion and extension. So it is motion in the sagittal plane about a transverse axis. And that transverse axis would essentially be established at the connection between those ribs, so 1 through 3, 1 through 4, and the vertebral segments that they are connected to. So rib 1 being T1, rib 2 being T1 and T2, rib 3 being T2 and T3, and so on. So that would essentially be sagittal. Then you get into mixed motion. So you have to understand what happens below that, and you're going to essentially see ribs 6 through 10 for the most part be called mixed motion, and some of that's going to be in relation to their connection to the common costal cartilage. But you're going to, the mixed motion is in between, so it's kind of like 4 and 5 or 5 and 6. It just depends on the source that you read. But more or less 6 to 10 are going to be, so it's pump handle and bucket handle. So the bucket handle is the lower ones, and that is essentially motion more or less in the coronal plane or the frontal plane. So it's almost like side bending, right? So that is going to be about an AP or a PA axis. Again, you have to agree with this. And then the ones in between those would be considered mixed motion. So it's kind of in between those planes, in between the pump handle and the bucket handle. Then you have ribs 11 and 12, which are considered caliper motion, right? So I'll get my hands in here. It's kind of caliper motion. So that would more or less be rotation or movement in the horizontal plane about, or the transverse plane about the vertical axis. Now, if you consider the connection of all of these ribs to vertebral segments, and that the rib heads, they may have some angulation to them at those connections, but basically the motion that is allowed to them because of the nature of their shape, as well as how many ligaments they're checked by, you essentially kind of more or less are going to have some degree of sagittal motion determined by that joint. That doesn't mean that's how it's experienced, which is why you get this variation in description. So pump handle, mixed motion, bucket handle, and caliper, right? So you essentially have all planes there. As a practitioner, it's going to entirely depend on where you observe the ribs from. So if you just observe them visually, or if you observe them with vision and palpation, what's going to occur is you're going to note expansion, so kind of bigger and smaller. That's what you're going to notice. And then if you're checking side to side, you're going to notice bigger and smaller being different or the same side to side. So if you're on the upper ribs on the anterior side, it's kind of going to go up. So if the patient's in supine, it's just going to go up and down. If you're on the mid-axillary line, so you're holding kind of underneath the armpits or on the side of the ribs, then you're going to notice out, right? So depending on observation, now if you were on those lower ribs that join to the costal cartilage and you were on the anterior surface, you would notice up and down, right? So depending on point of observation, you can have a different discussion. The biggest thing as a practitioner, what you're going to notice is kind of moving away or getting bigger, the thoracic cage getting bigger or getting full, or changing its volume and getting smaller. And you'll notice a difference between the sides, such that thinking about the particular planes and axes doesn't necessarily relate to what you're going to experience. The thing that you're going to experience is going to be change in size or change in position, being equal side to side based on point of even observation, or unequal. And when it's unequal, you are going to know what to do. The terms being inhale, so deep breath in, so cage is going to get bigger or move away from the middle, and then exhalation, cage is going to get smaller and move towards the middle. That's what you're going to notice. So if you stay with inhalation and exhalation as opposed to pump, mixed, bucket, and caliper, it's an easier thing to interact with, because it also depends on where you pay attention to it. So if you're in the mid-axillary line and you're paying attention to the caliper motion, it's still going to kind of get bigger and smaller. If you're, if you could kind of get the arms out of the way and you could get really way up into the axilla, comfortably so, it would feel more like a bucket handle, even when you're, high up on the ribs. So their motions are different because the shapes of the bones are different, but the experience of them is more important to pay attention to, because what you're looking for is symmetry of motion in expansion and contraction, or in inhalation and exhalation, such that I would suggest thinking about, so as an underpinning, as the ability to talk to different people with different perspectives and different professions, to talk about rib motion with pump handle, mixed, bucket handle, and caliper, the discussion is going to go pretty smooth. But what you're going to experience as a practitioner is going to depend on what and where you're observing. So if you're observing on the anterior surface, on the lateral surface, on the posterior surface, the thing that stays the same is bigger, smaller, right? That it's the inhalation and exhalation that stays the same. So my suggestion is to pay attention to that, although there is value in having that underlying discussion. Now, looking at the muscles of respiration. So your muscles of quiet breathing, essentially what they're going to say, and you can see it here, expiration, so muscles, so first we'll go muscles of inspiration, rather. Your general muscles of inspiration are going to be your external intercostals, so they will essentially raise or pull up because of fiber direction, more or less, but the pull's not going to be gigantic. And then you're going to have the diaphragm, so as the diaphragm descends, the thoracic cavity gets larger, and then that does most of it. So the descent of the diaphragm makes the thoracic cavity larger to drop the pressure to create a vacuum. So you make the cavity larger, keep the contents the same, the pressure drops. And then the gradient for breathing, so atmospheric pressure outside of the body versus the thoracic cavity. When you make the thoracic cavity larger by dropping the diaphragm, you create a pressure gradient. So the pressure drops with respect to the external environment, and then you create a vacuum. So that most of inspiration is done by the diaphragm. Some in a quiet setting may be done by the external intercostals. Now, as far as inspiration or active inspiration or accessory inspiration, you're going to have the scalenes going to lift ribs 1 and 2 as a group. So you could talk about the specific scalenes, but it's not necessary, but the scalenes are going to lift ribs 1 and 2. there is going to be some degree to which SCM is considered because of its connection to the manubrium, right? So that it can pull on the manubrium a little bit. You're going to see variation in this. So some places you look, you may not necessarily see the SCM included. You may see it included. Pec minor, because of its connection to ribs 3, 4, and 5, can do some of it. You can have a discussion if you want to get really granular about whether you agree with that or not, but basically muscles that can lift the ribs, and especially the upper ribs, because there isn't necessarily something that can lift the lower ribs because of how the muscular connections work. So as far as quiet breathing and muscles of expiration, it's essentially the passive recoil, right? So as it gets bigger, as the diaphragm descends, you drop the pressure, air comes in, pressure increases, and then what you're going to do is just going to be elastic recoil. So they get to a certain size and they come back. So the lungs come back, and the cage and the diaphragm do the same. Now, as far as active exhalation, it's internal intercostals, innermost intercostals, as well as the abdominal muscles. So the rectus abdominis, so rectus, internal, external oblique, and transverse abdominis, because they can pressurize the abdominal cavity. They can squeeze on the abdominal cavity. So what that's going to do is increase the pressure of the torso. And then you can talk about increasing the pressure of the abdomen will help to push the diaphragm up. So you're minimizing the size of the thoracic cavity. And when you maintain the contents but minimize the size, you increase the pressure. So now you're trying to reverse the pressure gradient, increase the pressure inside the cavity to above atmospheric, or what's outside the body, to basically create the pressure gradient to push it out. And you can also consider it as a bellows. You basically squeeze everything. So the abdominal muscles can help do that beneath the diaphragm, whereas the internal and innermost intercostals would help that within the cage. Then the QL can also pull down on rib 12. So there is some degree to which it will be involved as well. But again, varying levels of discussion if you want to get really granular. But very generally, quiet breathing is the diaphragm almost on its own. Descent of the diaphragm, increasing the size of the thoracic cage, or increasing the volume of the thoracic cage will drop the pressure, and then changing of that, so the elastic recoil on that as the diaphragm goes back upwards, what you'll have is an increase in, or a decrease in size of the thoracic cavity, maintaining the contents, but decreasing the size, which will increase the pressure, and then you get your pressure gradients. Once you go to active, more or less SCM, scalenes, and pec minor is what some will consider. Some may add others, some may talk about trapezius, but that's a more tenuous connection because it doesn't necessarily connect directly to the ribs. And then you're talking about also with inhalation is the external intercostals with active exhalation, abdominal muscles, and QL more or less, as well as internal and innermost intercostal. So lots of rambling to say something fairly straightforward, but to get the concept, especially why all this muscular contraction matters with respect to changing the volume of the thoracic cavity, as well as the pressure gradient for the movement of air. Now, as far as the innervation, so the innervation to the the diaphragm is from the phrenic nerve, so C3, C4, C5, coming out of the cervical plexus and descending down. It also innervates the pericardium to some degree, but it innervates. It is motor to the diaphragm. So for the most part, this is more or less reflexive. It can be both involuntary controlled or reflexive. And then when active breathing needs to come in, it can become more or less, it's like moving any other part. It's active motion. So it can be controlled both reflexively and actively through both the phrenic nerve. And then that's going to relate to the cerebellum, and it's the apneustic and pneumotaxic centers. So one is active breathing and one is passive breathing. So kind of the on and off. So you can have conscious control over respiration and unconscious, or active and reflexive. And that's all innervated, at least with respect to the diaphragm, to the phrenic nerve coming out of the neck. Now, as far as the rest of the muscles, so if we're talking about, and I'll just go back to this because it'll give some concept of where some of this comes from. If we're talking about the SCM, then what we're talking about is the accessory nerve, a cranial nerve 11. If memory serves me right, I believe it's cranial nerve 11, but it is the accessory nerve, also innervating the trapezius. Then you're talking about, with respect to the scalenes, anterior primary rami or segmental branches from varying levels of the cervical region. So the C1, depending on the source, C1 may be all the way down, but sources will vary. But anterior or segmental branches off of the anterior primary rami for the scalenes. Pec minor, I believe, is the long thoracic nerve, or maybe the pectoral nerve. That's not clear, but you're getting some out of the brachial plexus there. So you've got cranial innervation, you've got cervical innervation, so cranial for the accessory nerve, cervical for the scalenes, and then cervical again, but in the brachial plexus for the pec minor. So if you're considering the neural tone to those muscles or accessory respiration, you're chasing a reasonably large area and span. So physically, kind of from the thorax up through the neck, you've got to check everything if you're chasing the nerve. So it can become quite confusing. But what you're really looking for is a lack of motion. So as far as the muscles of accessory respiration, as well as the diaphragm, basically you're talking about the neck where it's located, but then it's got to descend. So any issue with motion between there, if you believe that there's a mechanical correlate to interference with the nerve and the function of respiration, you've got a large area to chase, but all you're looking for is the motion dysfunction. So sometimes it's smarter to just look for the motion dysfunction and deal with that, because your behavior is more accurate to the problem that is at hand. Now, as far as the intercostal muscles themselves and the abdominal muscles, it is the intercostal nerves. So coming off of the anterior primary rami in the thoracic region, going around essentially through the intercostal groove. So it's vein, artery, nerve. It's going to innervate the muscles, the intercostal muscles, as well as the muscles of the body wall, which would include, in this case, the internal, external obliques, the rectus abdominis, the transverse abdominis. The internal oblique, I believe, gets some from the lumbar region or the upper lumbar possibly, but it's going to depend on source. So you've got a large amount of intercostal circulation for exhalation. So it's almost like inhalation is the neck, exhalation is intercostal. You can split it up that way. I wouldn't necessarily suggest doing that while you're performing assessment and treatment. I would say just assess and treat motion. You can think about the connections after, but one connection you can make is that exhalation is more about the intercostal nerves. Inhalation is more about cervical nerves or nerves in the cervical region. Now, as far as circulation to the muscles, you're quite a bit, as far as the abdominal muscles are concerned, you're speaking about posterior intercostal circulation, anterior intercostal circulation, so internal thoracic or internal mammary, leading to the epigastric circulation, and then the iliac portion of the epigastric circulation, the posterior intercostal arteries, going in between the ribs, supplying the intercostal muscles as well as some of the abdominal muscles to some degree. The circulation for the SCM is going to be off of the, I believe, the external carotid, and then you're going to have the scalenes, I believe, receiving some from the external carotid. There may be some other branches, but you're talking about carotid circulation very broadly speaking, and the place to track carotid circulation is the SCM. The pec minor is more likely going to receive some branches off of the subclavian, be it internal thoracic, but not as likely, or maybe some collateral circulation, as well as going into the axilla or the axillary artery. So you're going to have varying branches from varying places. So if you're considering circulation for all of these respiratory muscles, you've got a large area to check. So again, if you're chasing circulation, it's not as intelligent or as accurate as finding the motion that's the problem. So this is just looking at what would be more so to the abdominal muscles. So we've used this image before when looking at the thoracic region. So you've got the internal mammary or internal thoracic, and epigastric, and then the iliac portion of the epigastric circulation. So you've got a bunch going on there, and then also the circulation more so to the pec minor coming off of the axilla or the axillary artery. Then you've got carotid circulation for the muscles in the neck. So you've got a large area to check, whereas you're smarter to just check motion and think about it after. Then the azygous system, as far as drainage with respect to the intercostal circulation, as well as some of the abdominal circulation or the abdominal wall circulation. the azygos being the right side being the azygos vein, the left side being the accessory and the accessory hemiazygos and the azygos. As far as getting into the function of the lungs, we first want to talk about pulmonary circulation, which we did mildly when we discussed the heart in one of the thoracic sections, or the thoracic, I believe it was thoracic extension when we talked about this. But your pulmonary circulation is essentially related to gas exchange, not necessarily supplying the lung. That's bronchial circulation, which is part of systemic circulation. So pulmonary circulation is you have the inferior and superior vena cava going to the right atrium, blood goes into the right ventricle, comes out to the pulmonary arteries. Now the pulmonary arteries are delivering deoxygenated blood into the lung. Now when it gets into the lung, it's going to go essentially into a venule around the capillaries, where you need to set up your concentration gradient. So it's going to get into the capillaries, and that's where the diffusion of gas into and out of blood will occur, where you need appropriate concentration gradients, which is one of the reasons why it's so important to be able to control the pressure environment in the thoracic cavity. Because if it's inappropriate, you can, at least to some degree, change the pressure gradient of the blood from external pressures, or a lack of change in external pressures, which will affect gas exchange to some degree. The degree to which it would change, depending on a particular amount of change in rib excursion, isn't necessarily clear, but it is at least something that you can predict will have some effect. Not a large effect, but some effect. So you've got it going to, so pulmonary veins, deoxygenated blood, venules, capillaries. Now, once the gas exchange occurs, it becomes arterial blood, but as it comes back to the heart to go to the left ventricle, and then to the left atrium to go into the aorta, essentially, you have pulmonary veins. Those pulmonary veins are a return system to the heart, to the left ventricle, but they carry arterial blood. So it's essentially the only place, or one of the only places, you're going to find arterial blood in what is named a vein. It's named a vein because it's returning to the heart. But then it goes out into systemic circulation. Now, as far as bronchial circulation is concerned, that is going to occur after it's come out of the left ventricle and gone into the aorta. So essentially what you're looking at for the most part is after the arch of, so you've got the ascending, the arch, and then the thoracic or descending aorta, you're going to have the intercostal arteries coming out. And then sometimes you will have bronchial branches from intercostal arteries around the right, or like around the bronchi, or you will have arteries that are coming out essentially as right out of the aorta as bronchial arteries. So they're going to follow the bronchi and then go and supply essentially the general tissue of the lung. So the blood supply to the lung is systemic and coming off of the bronchial circulation, which is directly either off of an intercostal artery or directly from the aorta. And then you have pulmonary circulation, which is for gas exchange, and they're not the same. So that's something to understand. But as far as being concerned, if there's a problem with pulmonary circulation, the area versus bronchial circulation, the areas that you would be looking at are the same, which again relates to why you look at motion, not necessarily aim at a particular function. You look at motion because you can identify it, and there's so many things happening in a small area, you can't pull them apart from your point of observation. So you pay attention to the motion because it will allow you to more accurately respond to the situation at hand. Now, as far as innervation to the lung is concerned, I'm talking about the pulmonary plexus. So the right and left vagus nerve will essentially mingle around or give branches around the bronchi or the bronchus or the bronchi, however you want to say it, the main bronchi, and start to trace that. But it will also mix with fibers that are coming from the preganglionic fibers are from the thoracic region. So T1 to T4, T1 to T5, depending on where you look. The postganglionic fibers will more or less go straight out and then wrap around the fibers that are aimed for the lung will wrap around the bronchi and mix with the vagus, or kind of take a similar travel, and then they will innervate the lung. So your sympathetic is coming T1 to T4, T1 to T5, preganglionic being there, postganglionic after the sympathetic chain will be essentially direct and aim at the the bronchi as the vagus gives off nerves to the bronchi or branches the bronchi, and then follow the bronchi to provide sympathetic and parasympathetic to the lung. The lung pleura, so you have the covering basically being a fold. So you've got the parietal pleura that's more or less right inside and connected to the intercostal muscles or the intercostal fascia. And then that folds back over itself to become the visceral pleura. And then there's space in between where you're going to have a serous fluid so they can slide over one another to whatever degree they have to and that also is helpful in maintaining the pressure gradient to the lung. So if you have essentially a pleural opening or a hole in the pleura, the lung will collapse because the pressure can't be maintained. So the parietal pleura folding back over to become the visceral pleura and essentially containing the lung, so separating it from other things so it can do what it needs to do, but allowing for motion as well. And then also wrapping around all of the vessels and the nerves and allowing for orderly transport as is needed. That also heavily maintains and helps with the pressure gradient differential to allow for gas exchange. So when there's a hole in the pleura, then you're going to usually end up with a collapsed lung, and I believe the term is pneumothorax is usually the term that will lead to the hole in the pleura, which will lead to a collapsed lung. And then that hole has to basically get healed or covered or plugged before you can reinflate the lung. And a lot of pneumothoraxes that I've heard of will be called self-limiting because they will heal and then the lung will reinflate on its own. Now, as far as the gas exchange itself, as I noted, it occurs. So you've got the pulmonary vein pulmonary artery bring deoxygenated blood, pulmonary or venule, pulmonary capillary. Gas exchange occurs around the alveoli, which are the small sacs. They've got multiple things going on. So they've got surfactant to change the surface tension, and then allowing for that gas exchange to occur in both directions at the pulmonary capillary. Then it goes through the pulmonary arteriole, back to pulmonary arteries, or pulmonary veins, rather. No, so I mixed it up. Pulmonary arteriole, pulmonary. So pulmonary artery, pulmonary arteriole, capillary, pulmonary vein, venule, pulmonary vein. So I just want to make sure that I say that right. So it's almost like a reverse circuit. It's the same circuit that you would expect in most exchange between tissues. It's just that the pulmonary artery and arteriole have deoxygenated blood, where the pulmonary venule and vein have oxygenated blood. Now, this is heavily dependent on pressure gradient. So the pressure of, I believe the term is PaO2, or the partial pressure of oxygen in the alveoli is generally 100 millimeters of mercury, whereas in the arteriole or in the capillary, it's 40 millimeters of mercury. So there's a pressure gradient where you've got high pressure in the alveolus or the alveoli and low pressure in the blood vessel, so that it can basically use gradient transport or diffusion. It's not perfect diffusion, but it's against or along a normal pressure gradient, so from high pressure to low pressure. Again, this is why the movement of the ribs have the ability to have an effect on the ability to maintain that appropriate pressure gradient for proper loading and offloading of gases from between blood and essentially the airway or the alveolus. So gas exchange is heavily dependent on pressure gradients, which is, again, why there's a relationship between the ability of the ribs to move or the thorax to move and maintaining pressure gradients appropriately for things like this. Now, the areas of consideration for assessment and treatment are exactly the same as with the thorax itself, or thoracic flexion, thoracic extension, thoracic side bending rotation, because there's no point at which the thorax is going to move without the ribs. So you're generally looking at the ribs and the T-spine broadly. So you're looking at thoracic motion, generally speaking, be it flexion, extension, side bending, rotation, or some combination of the three. Rib motion, so inhalation get bigger, exhalation get smaller. You want those to be even side to side to the best of your ability to observe and interface with. The things that you want to have caution with: known or suspected fractures or tears. Again, ribs do fracture. Usually not a terrible deal for lung function, but very painful for the patient. You're unlikely to have intercostal tears. You may have intercostal strains. The And again, those are quite painful, but you want to be very careful with those, because if you work on those, you can cause quite a bit of discomfort as far as the intercostal musculature or even the abdominal musculature. The abdominal musculature is a little bit more likely to have a tear, but the fractures, you want to be careful that you don't put pressure on those because you may worsen the fracture. You can also have fractures in the T-spine, but the thing that would cue you to that is recent trauma, the known or suspected thoracic aneurysms. So those are not easy to detect for somebody working from the outside of a patient, such as a hands-on practitioner. However, if there are reasons that a physician has considered it useful to have an image of the thoracic contents, then it's entirely possible that a thoracic aneurysm may be noted. And if it is noted, you want to be extremely, extremely careful, because increasing pressure on the thorax externally by a practitioner has the ability to at least some degree to affect the pressure on the wall of the aneurysm. So you want to be very careful with that.